All right, guys. So I thought class was at 2:30, like it was on Monday. It is not. It is now. So, good news is I still will not take it the whole time. So everyone that wanted to go home still gets to go home early. But we have three topics today. They kind of all go together. So we have transgender affirming care, which is going to basically blend what we talked about on Monday, and then also Dr. Cohen's material on how to go backwards and forwards. And then also we have erectile dysfunction and alopecia. We're kind of entering into the men's health stuff that will also cover some after Thanksgiving. So our objectives for transgender affirming care, I want you guys to be able to differentiate between the options for masculizing and feminizing hormone therapies. Look at the timelines for when patients can expect to see phenotypic changes. When I say phenotypic changes, what do you think I'm talking about? Physical, good. So remember phenotype, genotype, all the way back from bio, it comes back. So phenotypic changes that occur when initiating transgender affirming care. Discuss gender and sex-specific considerations for patients receiving transgender affirming care, and developing a monitoring program for patients on masculizing or feminizing hormone therapy. So transgender individuals via reporting represent about 1 to 2% of the U.S. populations, but that is the patients that are reporting to be transgender. But there may be more patients that identify that way but do not report, either to not feeling safe to report or they still having an identity not as transgender, but as the gender that they have decided to pick. Transgender patients, because of just the nuance of everything, but they're feeling some like gender identity separation from what their body is presenting as. They experience a lot of social determinants of health, including mental health disorders, specific health conditions, and some of that's also due to their environment. Transgender patients are increasing in number, especially in young adults. So by the time you guys start practicing, it will be more commonplace that you might have a transgender patient. When we talk about gender-affirming hormone therapy, or GAHT, this is therapy that patients may require to address the feelings of gender incongruence that they feel. So they want to basically start therapy so that they can feel and look and present as a gender that they identify with. The primary goal is to align their physical characteristics with their personal gender identity. And it is very important to provide education on the impact of therapy. So the impact of therapy on the patient's fertility, the adverse effects of the therapy, and the long-term risk of therapy. Is a decision that the patient needs to make, and it's very important to counsel them, not to sway them any which way, but to tell them everything that encompasses with it, because sometimes patients will start therapy and then stop therapy, and there is a point where they have to see it through. And if the patient is not aware of that, sometimes it can be devastating to them. So it is important to go over all of this beforehand. There are some areas I know in the state of Mississippi where I first started practicing, patients had to sign multiple waivers, basically, and go to the court and sign a waiver with a judge saying that they understand what they are asking for. And in certain private institutions, and they say it was banned. They could only get it done at the public hospital, just because of the salary from religious reasons and all the things. So when we look at masculizing therapy, the backbone of therapy is going to be testosterone therapy that you guys are already experts in because you had a wonderful teacher. The mechanism of action is that it's going to suppress the estradiol concentrations and reduce those feminizing effects. So you guys remember, testosterone can get converted to estrogen, but they're basically going to flood with testosterone, and basically you have too much testosterone that can't convert to estrogen. You reduce that estradiol concentration. There's no preference on dosage forms and routes, so it's based on patient preference. So all of those dosage forms that we went over, there's no preference on which one to use. It's what the patient wants to use. And the use of testosterone for gender-affirming hormone therapy is off-label. They're approved for hypogonadism and not gender-affirming hormone therapy. So it won't be covered on insurance sometimes for patients that have to pay cash. Here, this is a chart really to just let you guys know what all can be used and what has been used. You guys don't have to memorize these doses at all. And so some clinical pros of maximizing therapy is that you're going to adjust the doses by 20 to 25 milligrams. Every 2 weeks dosing is going to give greater peaks, similar to why we prefer the injections on Monday, because you have those peaks and valleys that are seen. naturally in testosterone in men who are assigned like men's sex at birth. They are available as 1, 5, 10 milliliters vials, and they contain cottonseed and sesame oil. And that's for testosterone cypionate, testosterone decanoate. It must be administered in a healthcare setting. Less consistent PK, and it contains castor oil. So if any patients are allergic or have dietary restrictions, those oils you want to communicate to them. For the gel, the dose adjustments are limited by the product packaging, must be on skin, understood for 4 hours after administration. Risk of transfer through skin, like what we talked about on Monday. And for monitoring, which is one of the last objectives, so before initiation, you want to get a serum testosterone, estradiol, lipids, and CBC. Every 3 months, a patient is going to get a serum testosterone level, hemoglobin, hematocrit, and full transition target concentration is going to be 400 to 700 nanograms per deciliter. So we know that a patient has reached their full transition when you get a free testosterone level taken at what time of day? In the morning, good. Full testosterone level in the morning, and you have a target concentration of 400 to 700 nanograms per deciliter. The risk for masculizing therapy is going to be polycythemia, and if that develops, you want to reduce the dose, increase in cardiovascular risk, and infertility. Go ahead.
Are they taking that for how long? For the rest of the life?
So not for the rest of their life. So how long depends on the patient, because when you have patients taking masculizing therapy, there are patients that were assigned female sex at birth. Even within patients who are assigned female sex at birth, there are different estrogen concentrations, so it just depends on where their baseline is. But you're trying to, well, they are trying to, but you're monitoring to get them to that 400 level. Go ahead.
So do you start the therapy when it's like at this range?
So once it's at that range, you can stop therapy. Some patients still decide to stay on it just because they may not have as much phenotypic changes as they want. Some patients also stay on it. So there are cases where some patients that were assigned female sex at birth do want to keep some level of a cycle, and so they may not target all the way to 400 because they still want to have children and do that. And so they may come off of it, allow for the concentrations to come down, get a cycle, have a child, and then go back up. Normally, those are patients that haven't made the full transition to where every time you pull their testosterone, it's within the 400-700 range, but it's very patient specific. So that's why you kind of have to go with your patient and have very open discussions. Go ahead, Kingsley.
So when you pull off the treatment, does it reverse?
When you pull off
Testosterone treatment, do you have a reversal of phenotypes? Since the testosterone is no longer coming in artificially, and the body is not producing it for that female.
So if they reach this transition target and you were to pull a level and it's in that, they have basically transitioned to the other.
Now, I mean, at that point, if you stop the medication.
If you stop it.
Yes, if you stop the medication, testosterone, the levels will keep going down.
They can go down. Some patients they don't, some patients they do. So yeah, that's why you want a full transition target of this. And so, but patients, if they stop therapy, depending on the patient, it sometimes can decrease. So that's why it's a lot. And we don't have a whole lot of studies on this, but this is the most up to date. I looked at this over the weekend to make sure. But this is the most up to date thing that we have. But basically, as long as patients stay within this target, their gender identity and their sex chemically has changed. But if they can go below, if they stop therapy, unless they've reached a point where their body's actually making. Timeline to phenotypic changes, they may be seen within 3 months for most individuals. Most changes have a maximum of 1 to 5 years duration. Deepening of voice, clitoral enlargement, and hair loss are likely permanent changes. All other changes are not likely permanent. when we think about pregnancy, lactation, and contraception, transgender care individuals, they require mostly the same care as cisgender individuals. So if you have a patient that identifies as transgender, but they are pregnant, or they are using contraception, or they are experiencing lactation, they require mostly the same care as cisgender individuals. Trans masculine patients should stop testosterone therapy before attempting pregnancy, and they can breastfeed after delivery. Contraception is recommended because pregnancy can still occur while on therapy. Because when they start therapy, they may not be at target dose, or there might be those peaks and valleys within where they're at in their testosterone levels, and so they can still get pregnant.
One more clarification. So if at 400 to 700, they don't have the phenotypic changes, do we still classify them as having transgender?
Yes, because they have the level. So
the testosterone level is our marker.
That is your marker. Phenotypic changes are not your marker. Phenotypic changes are what the patient's marker is, but the medical marker is the testosterone and to come up the estrogen. But your patient, their marker is going to be the phenotypic changes because they can't wake up and take their own level. For feminizing therapy, the backbone of therapy includes two classes of drugs. So you have your anti-androgens, which are going to decrease the androgenic effects of the endogenous testosterone that's made. And you have estrogen, which is used to induce the feminizing physical characteristics. They're all off-label, and injectable formulations of estradiol are FDA approved for IM route only, so not sub-Q. We have feminizing hormone therapy. You have your different estradiols, and then your finasteride, dutasteride, and spironolactone. Once again, you don't have to memorize these doses. Estrogens, there's no one dosage form or route that's recommended over the other. In patients that are 45 years or older, if they have history of VTE, then the patch is recommended over other routes. So if you have patients 45 or older, or they have history of VTE, they need to get the estradiol patch. IM or sub-Q estradiol, you adjust the doses by 0.1 to 1 milligram. You're going to consider every 2 weeks dosing for those greater peaks. These also contain cottonseed and castor oil. And you have transdermal estradiol, where you can greater than 2 patches at a time may be cumbersome for patients. So we say that they need to use 2 patches at a time, and it's dosed once or twice weekly. When we go to our anti-androgens, they're primarily used to minimize estradiol administered. So patients don't have to give as much estradiol because they also have anti-androgens. Your spironolactone is the primary agent used in the US. It functions as a selective estrogen receptor modulator, may be dosed twice daily. And the dose you're gonna adjust by the serum testosterone concentrations and clinical response. Because this is feminizing therapy, so you don't want testosterone concentration. So based off the clinical response and the serum testosterone concentration, if you see higher testosterone, you're going to be able to give more of the spironolactone. Finasteride, dutasteride, you have your 5-alpha reductase inhibitors, and these suppress the conversion of serum testosterone to dihydrotestosterone in tissues. And these also you adjust based off of clinical response. Then we have progestins, which are used in some practice but not recommended due to the lack of evidence for efficacy and safety. The progestins are used to help make breast development, mood, and libido. They're associated with weight gain, depression, decreased HDL, which is our good cholesterol, and increased risk of clots. The progestins are going to be your medroxyprogesterone oral acetate, your medroxyprogesterone, the IM sub-Q version, and micronized progesterone. So when we go to monitoring for feminization therapy, before starting therapy, we're going to get a few more labs than we did in the beginning for the masculizing therapy. They get a BMP, estradiol, and testosterone, a lipid panel, and LFTs. Every 3 months, you're going to get an estradiol and testosterone concentration. In patients with spironolactone, you're going to look at serum, potassium, and creatinine. And patients who want full feminization, should have concentrations of estradiol in 100 to 200 and testosterone less than 50. So those are your target concentrations. So when you're thinking target concentrations for testosterone, 400 to 700, and that's for masculizing therapy. For feminizing therapy, 100 to 200, and a testosterone less than 50.
Okay, this is and, not or.
It is and.
So if one of them is off target, it's still not touched.
Yes. And because feminizing therapy, you need less testosterone, and then you also need estrogen. And that's because testosterone can become estrogen, but estrogen can't become testosterone. Looking at risk for feminizing therapy, the primary safety concern is risk of VTE with estrogen use, secondary infertility, and in spironolactone patients, hyperkalemia, which makes sense. What's another thing you might be worried about in a spironolactone patient? Gynecomastia, in this case.
Yeah, in this case, you're gonna really be
In this case, they're not worried. It's welcome.
It's welcome.
What's spironolactone used for?
What also during diuretic?
Yeah, diuretic. So you with diuretic, yes, diuresis. But with diuresis, you can have low what? Blood pressure. Just make sure that they're not having dizziness. Make sure they're not having any of that. They won't have significant, but you just want to make sure. Timeline of phenotypic changes. They can start to see changes within 3 to 6 months. Likely permanent changes is going to be breast growth, decreased testicular volume, and decreased sperm production. It is important to counsel the patient to expect realistic changes. So patients might develop some breast tissue, but it might not be the breast tissue that they would like or that they envision. And some goals may not be achieved by therapy alone. So some changes might require surgical intervention for them to get their presentation that they would like. And I'm gonna leave that there. So gender and sex specific considerations, you wanna look at renal function evaluation. You're gonna use your Krakow-Gault to estimate GFR. If you're using Krakow-Gault to estimate the GFR, you wanna use the gender that the patient wants to be at. So you want to use that gender because that's what they're becoming.
By using the gender assigned at birth, they want the weight.
So once they start treatment, so before they start treatment, you use the one they assigned at birth. Once they start treatment, because they're becoming that and transitioning to that, you're going to use that gender. Serum creatinine is increased in transgender men from 0 to 6 months. So 0 to 6 months of therapy, calculate the eGFR with sex assigned at birth, then transition to gender identity in transgender males. And then transgender females use the sex assigned at birth. So 0 to 6 months with transgender males, you use sex assigned at birth, and then can transition to gender identity. And transgender females use sex assigned at birth. Because this is confusing, I went and asked you this. Because it's confusing. But this is for you to have as a slide so that if, let's say, you're on rotation and you have someone in internal medicine or acute care and you need to figure out how to dose their antibiotics, you can be like, oh, my professor gave me a slide. But this is confusing, so I will not ask you a question like this. Because I said that if I do ask you a question like this one I will give back, because I said I would. Y'all can tell me at minute, whatever this is, at minute 19 and 29 seconds, I said I wouldn't do it. Y'all don't do that when professors, y'all don't do that when professors say I'm not gonna ask, y'all don't go back on the report and be like, at this time they said they wouldn't do it, so if you see it on the test, you can go back and be like, you said.
Thanks for the heads up.
We did that all the time. My professors hated me. I was clocking every minute. You said 30 minutes in, you were going to do this. I saw what they said. Well, and I paid for you to be honest. So all gender identities are going to get an HPV vaccine, an anal pap smear in high-risk patients. If they are assigned female at birth, they get a breast exam. If they had a bilateral mastectomy, a mammogram is not recommended. Only a physical breast exam. If they have natal breast tissue, you follow local breast cancer screening recommendations. For cervical exams, if the cervix is removed, a cervical exam is not recommended. If there is an intact cervix, follow recommendations per cisgender women. If patients are assigned male at birth, for a prostate exam, consider getting a PSA and a digital rectal exam according to local recommendations. So, final considerations, along with transgender affirming therapy, it is recommended that patients get mental health support as well, because this is a very complicated journey that the patient has to go through. Surgical interventions may be recommended for patients who have goals to fully present as desired gender. So, right, some changes will happen, realistic changes need to be expected. If a patient does not like the changes that they have received or is not fully the way that they would like to present, surgical options are their options. Vocal training can be recommended for trans feminine patients who would like a higher pitch, and testosterone therapy will deepen trans masculine patients' voices. What questions do we have before we move to erectile dysfunction? Some of y'all look stressed. I did not mean to stress y'all. All right, so erectile dysfunction. So these are your objectives for erectile dysfunction. So the definition of epidemiology, so the definition of erectile dysfunction is persistent failure to achieve and maintain an erection to allow for satisfactory sexual intercourse. This needs to have happened for 3 months. So they can't have one time and then the couple came to you and said, we need, because yesterday or Valentine's Day didn't go to where I wanted it done. It needs to be 3 months. You can't be like, my birthday didn't go well. I'm so sorry. We try again today, it might be different. The minimum of 3 months. 3 million men in the US and 150 million globally are estimated to have erectile dysfunction. Very depressing epidemiologic bullet point. I need to remove it. Prevalence of 52% of men between age 40 to 70 years of age. There's lower incidence in men under 40. Go ahead, Kingsley.
So we said there is failure to achieve and maintain.
Mm-hmm.
Who determines that? Is it determined by the couple? It's important because it is determined by the couple, because when they come to the clinic and they say there was a problem there, is it determined by the couple?
It is.
So if the couple say it is, whether it is or not.
Yeah.
Oh, okay.
It's limited. No, I think it's limited whether it's
Uh-huh.
No, what I'm asking, it's important because I see a lot of people use medications, and I wonder why. That's why I want to understand whether it is something that is in the realm of psychology or in the sense of clinical. Because psychology is subjective, clinical is objective. This is not objective.
Now, I will say some patients, and you'll see in the next physiology slide, some patients with their comorbidities, you can kind of basically glean that it is a clinical presentation. But I mean, if they come in and they say, and you ask questions like, how long has it been happening? And they're like, over the past 2 weeks, you're not really going to investigate that. Versus if they were like, over the whole year, then you can kind of be like, okay. But also, the comorbidities will also help you lead to that. In men greater than 70, prevalence is up to 80%. And some of that is just because as time goes on, the body, certain things just don't continue the same way that they used to. So in normal physiology, there is a sensory stimuli. So during an erectile phase, arterial blood flow increases and is enhanced by acetylcholine-mediated vasodilation. So there's vasodilation through acetylcholine that basically increases blood flow into the venous. Acetylcholine, it can produce an erection through either the presence of sexual stimulation of the genital tissue and it results in relaxation of the smooth muscle and erection occurs, or you have testosterone that is basically stimulating the libido, and the androgen receptors in the endothelium of the penis results in a vascular process that causes an erection. So basically, if there is stimulation of the genital tissue, that's through acetylcholine causing muscle relaxation. And then there's also testosterone increasing libido, and that's causing basically receptors in the endothelium of the penis. That's causing the vasculature to have blood flow and cause the erection. So it's multimodal. This is in normal physiology. This is what normally happens. So pathophysiology-wise, there are abnormalities in any of the previous mentioned areas. So known as organic erectile dysfunction, which compromises 80% of patients. So there is a dysfunction in either the acetylcholine causing the smooth muscle relaxation, or the testosterone that's basically fueling the libido. There could be nervous system, which is basically diseases that affect nerve conduction to the brain or to the vasculature in the penis. There can be psychogenic stimuli, which is depression, mental disorders, cognitive disorders. There are vascular, which are diseases that affect blood flow, and then there's your hormonal system. So when we think vascular diseases, what are some vascular diseases that can affect blood flow? So coronary artery disease, peripheral artery disease, and some other risk factors. So I don't think you guys can see it because of the way it is. But if you guys look at your slides, there's a star there. You're welcome. So hypertension can cause compromised vascular blood flow. Coronary artery disease, that was said, hyperlipidemia, diabetes, smoking, and alcohol abuse. These are some comorbidities and risk factors that can cause ED. Medications that can exacerbate ED include antidepressants, so your SSRIs are your highest risk, anticholinergic medications, cardiovascular drugs, so your thiazide-like diuretics, beta blockers, spironolactone. Also, your diuretics decrease arterial flow, so that blood flow is not happening because you have the diuretics decreasing the arterial flow. Your hormonal agents, right, your 5-alpha reductase inhibitors, androgen receptor blockers, those decrease libido. Your CNS depressants, so opioids, benzodiazepines, they exacerbate ED by affecting your perception of stimuli. So because those cause you to be sedated, you don't get the stimuli, you don't get the response. And alpha antagonists. So diagnostic evaluation, the severity of it is through validated questionnaires. So Kingsley will have a long conversation with all the questionnaires to figure out that there's also differential diagnosis or other disorders of sexual dysfunction. So differential diagnosis being you have diabetes that's uncontrolled that's leading to sexual dysfunction. You have hypertension that's uncontrolled peripheral vascular disease that's leading to erectile dysfunction. Also history, so medical history, if you have medical conditions, surgery, social history, alcohol, tobacco, recreational drugs, or psychosocial history. And then you do an evaluation of the vital signs, weight, physical examination. You wouldn't be doing that. Cardiovascular risk assessment, and then labs, serum testosterone, A1C, lipids, thyroid function, prostate, specific antigen. When we look at our treatment approach, there is psychosocial support and lifestyle modifications and risk versus benefit of treatment options, and is shared decision making. So you will have a conversation with the patient and basically decide, do you want to do non-pharm, which you get psychosocial support, like make lifestyle modifications? Do you want to do that and PDE5 inhibitors? Or do you want to go some of the other things such as vacuum devices, intrauterine prostadil, intracavernous injections, or a prosthetic member? And then you assess the outcomes. So if inadequate, you can adjust doses, or you can partner with a mental health professional, or you can try other treatments. So it's shared decision making. So what is the patient comfortable with? What does the patient want to do? For non-pharm, you got physical fitness, weight loss, low cholesterol diet, limit alcohol, smoking cessation, and psychotherapy. This used to be integrated, so we got some structures. Dr. Rizzi is not putting structures up there. But this is the FYI. So when we look at the pharmacology of it, basically it inhibits type 5 cyclic GMP phosphodiesterase in the peanut artery for PDI inhibitors that cause vasodilation and engorgement. So your PDE5 inhibitors, that's going to be your sildenafil, your vardenafil, Cialis, Viagra, they are going to inhibit cyclic GMP, and that causes vasodilation and engorgement. You then have sexual stimulation and nitric oxide release, and that is basically required for the drug to work. It does not cause an erection without sexual stimulation. So the patient needs to take the medication and then have sexual stimulation in order for the drug to work. So what do you need to know from this slide? You need to know that it inhibits type 5 cyclic GMP phosphodiesterase, causing vasodilation. And that sexual stimulation and release of nitric oxide causes for the drug to work. Clear? Good. Awesome. These are PDE5 inhibitors. So you have evanderfil, sildenafil, tadalafil, and vardenafil. So Cialis is the one that patients like the most because it has the longest duration of 36 hours, even though it takes the longest time to do the onset of action. Sildenafil is kind of the more popular one. You do need to know the comments section, which ones to avoid with creatinine clearance less than 30, and also which ones you need to avoid in severe hepatic impairment over strong CYP4 inhibitors. So, not necessarily the main by mouth dosing, but you do need to know the comment section.
The ones daily dosing
Mm-hmm.
without regard to 6 hours. Why is it lower than the one 6 hours?
The once daily dosing.
So they take 5 mg. That's it for the whole day. That was gonna keep them enticed for sex throughout the whole day.
So the once daily dose, okay, I get it. Get what you're asking. So the once daily dosing, the 2.5 to 5 milligrams a day without regard to sexual activity, is for them basically for them to be ready at time. So if they aren't able to plan their timing or they don't want to plan and they want to keep a level of spontaneity, they can take that and then that's the daily dosing. Whereas if they want to take it as needed and they know when they're going to have sexual activity, that's when they do the 5 to 20 milligrams. So if they plan, and this is why you have to have these shared decision making. So if they're like, well, we don't really have planned times, we would like to keep a level of spontaneity, or whenever, things occur, then it's better for them to have the once daily dosing. That way, when stimulation occurs, they're ready versus as needed. It's like, okay, on Fridays, this is what this occurs. Therefore, I'm going to take it on Friday. Good question. So, typical starting dose is listed below. You're going to reduce the dose if they're greater than 65 years old. They're using an alpha blocker. They're using a CYP3A4 inhibitor or severe renal or liver disease. What are some CYP3A4 inhibitors? Grapefruit juice, yes. Amiodarone, good.
Macrolides.
Macrolides, yes.
Non-VHP calcium channel blocker.
Right. Verapamil, diltiazem,
Or antifungal.
azole, antifungals, all the zoles. Everybody study with George for the napkins. Or George, you pick who you want to study with, since you got the knowledge. They have it too, they just hide it. PDE5 inhibitor education, so important. You want to tell the patient that for best response, patients must engage in sexual stimulation. So for best response, they can't just take it and then sit there. They got to take it and then, be prepared. Administration is with high-fat meals. If they're taking vardenafil, high-fat meals may decrease the serum concentration up to 50%, and high-fat meals may cause low absorption of sildenafil. Tadalafil and evanafil can be taken without regards to meals. But the other two, they need to watch the administration of high-fat meals. They need to avoid excessive alcohol, and they need to manage their risk factors. So if they have uncontrolled diabetes, hypertension, or if they are dealing with obesity, they need to manage those as well. Because just giving them the medication, if they don't manage those, it's like putting a Band-Aid on a gash. Also have psychological counseling if applicable. When you need to determine treatment failure, you need to determine if they're doing proper administration in regards to sexual activity, if you've tried to titrate the dose upwards. Some patients may need 6 to 8 doses before they have adequate response. So first time, they may still be experiencing failure. It may take 6 to 8 doses before their body gets used to that and having an adequate response. Also, can't stress enough, evaluate the comorbidities. And there is potential for it to be psychological or hypogonadism, which requires treatment with testosterone. Adverse effects is going to be headache, flushing, dyspepsia, visual disturbances, so either blue vision, that's reported with sildenafil, dizziness, hearing loss, and priapism. Priapism is basically the patient is ready for longer than they would like to be ready. And after they feel like they're finished, they're still ready. It can cause permanent damage. So if patients are experiencing priapism, want to either reduce the dose or discontinue them. So drug interactions, you guys don't even need this slide. You guys knew it. So verapamil, erythromycin, ketoconazole, ritonavir, they can inhibit metabolism. So if patients are on those, you don't take them off of those meds, you just reduce the dose. For inducers, they can decrease plasma levels. So they get the starting dose and you may have to increase. They are contraindicated with concomitant nitrates. So patient can't be on isosorbide dinitrate, mononitrate, any nitrates they cannot be on. Also, there is clinically significant orthostatic hypotension seen with alpha-1 antagonists. Drug-food interactions, you guys already knew grapefruit juice can increase drug exposure, and concomitant alcohol can cause hypotension. And what you're going to monitor is for visual complaints, blood pressure, pulse, palpitations, dizziness, and hearing loss. Some other treatment options that we can use is testosterone, which we use for hypogonadism. These may enhance the effects of your phosphodiesterase inhibitors, but they're not indicated for patients that have normal serum testosterone levels or asymptomatic hypogonadism that we talked about on Monday. Patients can also use a vacuum erection device, which is a non-invasive medical device that patients can use if they can't take a PDE5 inhibitor. The negative vacuum pressure causes for blood flow, or they can use alprostadil, which is a prostaglandin E1, and it fills the corpora with blood. Or they can use invasive. Well, alprostadil is invasive because you have to either put it in transurethral or intracavernous. Basically means they have to insert it themselves. And people don't really pick that one. So key points, you want to identify the risk factors. So think vasculature and neurogenic cases. So why the patient is experiencing erectile dysfunction. Identify some medications that can exacerbate erectile dysfunction. If it's medication induced, once you remove the medication, you remove the problem. Pair non-pharm with pharmacologic options. And when they're on PDE5 inhibitors, you want to counsel on administration timing, treatment failure, contraindications, and adverse effects. Follow the stars. Y'all should be fine. Yeah.
Just wondering why since testosterone level will differ in individuals,
Mhm.
when they come with ED, why are we not titrating?
Since they would differ in patients, why do we not?
You know, people come at different testosterone levels. So when they come with ED, the previous people don't come with the same.
Mm-hmm.
I was thinking, I'm just wondering why are we not titrating the dose of the medication to find what will be optimal for them and just giving a straightforward dose.
For the PDE5 inhibitors,
Yes.
why we're not titrating the dose that would be best for them?
I'm just thinking about it.
Well, I mean, you would increase it if it's not helpful.
You start from a low dose and then you start.
Well, yeah, you start at the low dose. So titrate meaning they're already on a dose. If they are already taking a dose and it's not successful, you would go up. So I never said that you can't go up on the dose. I was not having you memorize the doses for the exam. But yeah, if they are still experiencing erectile dysfunction and they've addressed their non-farm issues and they're still not successful at that dose, you can increase the dose. Unless they have a contraindication based off of renal function, other medication therapies. But then also when talking about treatment failure, if they're still having problems maintaining an erection and they're on the max dose that they can take, then you can evaluate if they have hypogonadism and then give them testosterone. Because sometimes the patient might present with the erectile dysfunction first versus the hypogonadism. They might say, okay, I'm having problems sexually, and then you help them out, but then you realize, oh, it's actually hypogonadism. Because the patient isn't going to come in and tell you that I have low testosterone. Because they don't know that. But they will come in and tell you. I guarantee you. They will come up to the counter in a store and tell you that they're having problems and ask for Viagra. You have to be like, your doctor has to prescribe it. From lived experience, they will tell you. So alopecia, our last disease state. Thank you guys for hanging there with me. So alopecia is hair loss. And I believe I taught you guys this in self-care. Y'all were the last group to get it in self-care before we took it out. So hair loss epidemiology. So up to 50% of men and women will experience hair loss in their lifetime. Alopecia can have a major psychological, social, and economic impact. The most common cause of hair loss is hereditary, and it's called androgenetic or androgenic alopecia. And AGA is the only form that has FDA-approved OTC medications, and it's most common and most expensive in Caucasian men. So going over the hair cycle has 3 phases: the anagen, the catagen, and the telogen phase. And then there is an intermediate phase, which is returning to the anagen phase. So in the anagen phase, most hairs are in this phase. It's also known as the growth phase. And this lasts from 1 month to 6 years. This is when your hair is growing. Then you have the catagen phase, which is the transition phase. We have hair follicles. They start to go through apoptosis and reduce in size. And that lasts 2 to 3 weeks. Then you have the telogen phase. And you have 10 to 15% of your hair in this phase, and it lasts 1 to 3 months. And that's where your hair goes into a resting phase. And then there's the exogen phase where the hair falls out. So types of hair loss. There's scarring hair loss, which is related mostly to disease-based hair loss. So related to discoid lupus, erythematosus, sarcoidosis, syphilis, severe tinea capitis, or trauma. And you can know that scarring because something has happened. It's basically like traumatic hair loss. Then there's non-scarring, which is androgenic alopecia, also known as hereditary hair loss. Then there's alopecia areata, which is basically patients born with alopecia, anagen, effluvium, tinea capitis, and trichotillomania. So pathophysiology, androgens play a key role, especially in pattern hair loss. You have testosterone that's converted to dihydrotestosterone by 5-alpha reductase. Dihydrotestosterone binds to the androgen receptors with greater affinity, and then it shortens that telogen phase, and so it creates more hair loss. And patients that have androgen receptor polymorphisms, they're at an increased risk for hair loss. The clinical presentation, so it's no scarring and inflammation, and it's gradual onset and it's irreversible. So you won't see any inflammation or any scarring in AGA. You will just see pattern hair loss that's irreversible. In 15 to 25 years, that's about how long it takes to use all hair. And the pattern of baldness in men is frontal, so there's recession, thinning at the vertex. Women have more diffuse loss, so it's over crown and the mid-frontal of the scalp. And if women have symptoms of hyperandrogenism, then you would basically refer them to a specialist. So they have symptoms of hyperandrogenism, so they're losing hair on their head, but they have hair growing in other areas such as chest, under their arms, kind of wildly growing, and that's not AGA, that's hyperandrogenism. Diagnosis is usually made clinically, so through patient history and through skin and hair examination. Patient history, you're going to look at the time of onset, the past medical history, family history, so are there any other people in their family that have gone bald around this time? And also do a physical history, and then do a hair examination, a tug and pull test. Literally, you do a test where you just go, you can pull down, or some people, I don't think it's true, but some dermatologists will go like right at the root and do a tug and pull. So I've seen dermatologists do it. They'll do right here and then they'll do it and see how much leaks. Sometimes there can be suspected fungal infection, so they'll do a wood lamp examination if they think it's fungal. Treatment for hereditary hair loss, the goal is to achieve an appearance considered acceptable to the patient. So if you see hair growth but the patient's like, it's not enough, it's not enough. Some of this can be for non-pharmacological, it can be cosmetic camouflage, so sprays, gels, wigs, weaves, or low-level light therapy, or surgical transplantation of hair follicles. I know someone who literally went to Turkey to get a hair transplant. I mean, listen, he puts his do-rag on the way he's swimming. I don't got nothing to say about it. But he went and got a hair transplant, not on.
Okay, so coming to goal. Coming to goal. The goal is acceptable to the patient.
Acceptable to the patient.
But diagnosis is not acceptable to the patient.
What isn't acceptable to the patient?
In diagnosis, we are clear to say, okay, this is alopecia. Doesn't matter if the patient walks in and says, I think I'm losing too much hair, can we just go ahead and listen to the patient and on the basis of that, diagnose for alopecia?
Well, if they're losing hair, I mean, yeah, that's what it means when it says appearance considered acceptable to the patient.
That is for recovery, for goal.
Go for therapy, yeah.
Yes, but I'm talking about for diagnosis. So that also counts.
Yeah, I mean, if the patient says they're losing hair, they're losing hair. I mean, you do a tug and pull, and if hair falls out, you kind of know that way. But, I mean, unless you know the patient's baseline hair and where they're at, you won't be able to, like, tell them that they're not losing hair.
So what the patient says, I'm losing hair, you can as well go ahead and start.
I mean, yeah, because you're not going to be like, actually, you're not. Because you don't know.
Okay.
I mean, and I think also you have to think about it when it comes down to pure diagnosis. Like, you are not going to be looking at the scalp and doing that. Like, you're just not. So once it gets to you to recommend the treatment, it'll probably already come that they have alopecia, or a physician, if you're in ambulatory care, because this is where this will happen. If they say that, oh, I think my patient is experiencing it, you might be there, but like you as a pharmacist are not going to look in their scalp and be like, based off of what I see with your scalp, you're not losing hair. You be outside of your scope, and you don't have a diagnosis code to put in. So I mean, like, you can say I don't think they're losing hair, but the doctor's going to be like, okay, well, I'm doing the physical exam. Pharmacological therapy is topical minoxidil or 5-alpha reductase inhibitors. So for OTC, you have topical minoxidil, so the 2% or 5%. These are the only FDA-approved self-treatment agent for AGA. So for baldness at the crown of head or hair thinning at the frontal parietal area in females, it can apply twice a day for men, once a day for women. The mechanism is that for topically, it increases cutaneous blood flow directly to the follicles, and it enlarges the follicles and increases the anagen phase. So you basically cause more blood flow to go to the hair follicles, which increases the follicle size, allowing for more hair to come through the follicles, and also increases the anagen phase where the hair is growing. The oral mechanism is a vasodilator via potassium channels for hypertension. Dosage forms, they are hydroalcoholic solution with the 2% and the 5%. Men only can use the 5%. And then there's a solvent, free foam, which 5% can be used by women and men. So if you have the solution, the 2% for women, the 5% for men. If it's the solvent or the foam, 5% for both. The reason why you use the 5% only in men is because women have a higher risk for facial hair with the 5% product. Now, of course, if a patient's like, I prefer to use the 5%, I'm okay with that. It's OTC. They can buy what they want to buy. It's their money they worked hard for. But we tend to only use the 2% in women to prevent that risk of facial hair development.
Prof, sorry, the minoxidil,
Yes.
is the oral also OTC?
No.
The oral is prescription.
The oral prescription. Minoxidil efficacy, so higher doses work faster, have more regrowth, but they also lead to more itching, irritation, and hypertrichosis. Patients may see more hair loss in the first 2 weeks to 2 months. So patients will start using them, but my hair is leaving more. You'll be like, yeah, that's part of the process. Keep it on. The full effect is seen by 4 to 6 months. And it only works with continued use. So it's something that as long as they're continuing to use, they'll continue to see the hair growth. If they're all of a sudden stop using it, the hair will stop back falling out. Some of y'all faces is like, what do you mean? That's how the drug works. And it's mainly because you increase the follicle size and increase the blood flow to the area with the minoxidil. So then when you remove it, the minoxidil was increasing the blood flow and the follicle size. So now you think about it, if you close back that follicle size, not as much hair can get through anymore. And now you basically are reverting back to what hereditarily was supposed to happen. So the hair is going to fall out. Common side effects: local itching, irritation, and dryness of the scalp. Rare side effects that patients will need to stop for is acne, increased hair loss that goes beyond the 2 months, reddened skin, facial swelling, or systemic absorption, so low blood pressure, headache, vision changes, irregular heartbeats, and chest pain. Precautions for minoxidil: you want to use this in caution with patients that have cardiovascular disorders. You also do not want to combine this with topical corticosteroids, Vaseline, retinoids. So patients don't need to just go to the dermatology section of the community pharmacy, buy the kitchen sink, and be like, I just put everything I thought on my hair because I wanted it to grow. That's not what they need to do. They also cannot use it within 24 hours of a hair color or relaxant. So they go get hair color, highlights, lowlights, auburn, whatever's done nowadays. They need to wait 24 hours and then they can use it. They do not need to use it on patients that have scalp damage, sunburn, psoriasis, and patients also need to wash their hands after using it and rinse thoroughly if it gets in their eyes, mouth, or nose. These are the instructions. So for the solution, apply to a clean, dry scalp and hair. Allow for 2 to 4 hours to penetrate scalp. If using at night, 2 to 4 hours before bedtime. And they do not need to use a hairdryer right after application. So what?
There's nothing to dry, we don't have it.
This is not what you need to be. We're gonna find you a different disease than me. This is not for you. I'm gonna tell you early in your career. This ain't for you. All right. Foam. Wash hands in cold water and dry them before use. Pat dry hair into rows, or part dry hair into rows and apply half a capful. Let the hair dry. Pros is that it improves hair growth. It's easy application, and it's great for younger patients with early pattern hair loss. It's very devastating in your 20s to know that you were balding. One of my classmates at pharmacy school, actually, he started like balding our like P1 year, and he was like very devastated, and he was like, "I'm gonna do the minoxidil thing," and I was like, "I mean, I don't know." And then he started it, and then he decided to go all the way back. I don't know. He went through a lot. We have to have a lot of counseling. Cons, they may lose hair initially. Not everybody responds to treatment, so it's not guaranteed. Patients must be consistent. It can cost money. Twice a day application in men, and it will not completely restore hair. For systemic therapy, we have finasteride and dutasteride, which we'll talk a lot about in 2 weeks. They are originally used for BPH, but the efficacy for AGA was an incidental finding based off of a side effect of treatment. These are in men only. These are men only. Finasteride is a selective type 2 5-alpha reductase inhibitor that reduces scalp production of dihydrotestosterone. It causes increases in hair growth in men at 6, 12, and 24 months. The dose is 1 milligram a day, and you have dutasteride, which is a dual inhibitor of type 1 and type 2 5-alpha reductase, only approved for BPH, and that dose is 0.5 milligrams a day. For adverse effects, finasteride, orthostatic hypotension, dizziness, decrease in libido, and ejaculatory disorders. Dutasteride, sexual dysfunction, breast disorders, both are teratogenic, and skin contact should be avoided with them.
That's the right, it's an off-label use.
Yes. So, for hair care in patients with alopecia, chemical processing and manipulation of hair to hide hair loss and dyes can cause more damage. Hair should be combed or brushed when dry. Hair conditioner should routinely be used to coat and shaft smooth cuticles. And you can use an instant conditioner and then follow with leave-in conditioner to maintain the use of your hair. What questions you guys have for any of the 3 things that we talked about today? None? All right, well, send me an email if you do, because after tomorrow at 12, my Thanksgiving begins. So I will see you on the Monday after Thanksgiving.